what we were saying is that for diabetes, whether it's type 1 diabetes, type 2 diabetes, type 17 diabetes, they're all going to involve these three things: polyuria, polydipsia, and polyphagia. And so what I was explaining before, can you hear me okay? Yeah, okay, good. So what I was explaining before is that when you have a lot of glucose in your blood, some of that glucose is going to be filtered into the kidneys. And now it's the job of the kidneys to reabsorb that glucose back into the bloodstream. So kidneys are going to reabsorb some of that glucose, but you know, in diabetics, they have a lot of blood glucose. And so some of that glucose is going to continue down the nephron. It's going to continue down the descending loop of Henle, back up the thin ascending loop, through distal convoluted tubule, and out through the collecting ducts. Okay? So as the glucose is moving through the nephron, it's going to be drawing in a lot of water. Okay? Whenever you have a high concentration of a molecule, of glucose, of protein, anytime you have a high concentration of something, it's going to draw water inside. And so now this glucose is drawing water in, water is starting to accumulate, and you end up with a huge urine output. Okay? So good. So that's our urine output. Now that we are putting out all this urine, our blood volume is going to start to drop, and then our buddy antidiuretic hormone the levels there are going to increase, resulting in excessive thirst. Okay, so now your patient's peeing a lot, your patient's thirsty, and the third cardinal sign of diabetes, every diabetic patient will have this, is polyphagia. So why are our patients getting so hungry? Excessive hunger and food consumption. Well, if you think about it, the cells of the body, while there's plenty of glucose around, the glucose is not getting into the cells. So the cells are hungry, and they're telling your body, please go eat more, go get more energy, because we're not getting any glucose. But no matter how much this patient eats, those cells are still not going to get glucose. And so you end up with excessive hunger and food consumption. Okay? Okay, so now explain this back to me. What are the three signs of diabetes, and why do the patients have these three signs? Okay, so first sign, polyuria. This just means a lot of urine, right? The reason your patients have a lot of urine is because they have a lot of glucose in their blood. Okay? Lots of glucose in their blood. When that blood reaches the kidney, that glucose is going to go into the nephron. In the nephron, some of the glucose will be reabsorbed back into the bloodstream. That's what the proximal convoluted tubule is for. The PCT of the nephron is for reabsorbing glucose. However, because these patients have so much glucose, much of the glucose is going to continue on through the nephron. The problem there is that if you have things in the nephron, if you have a high concentration, especially of glucose, that is going to draw in water from the surrounding tissues. So you have water being drawn into the nephron space. Okay? And everything in the nephron space is ultimately going to leave the body as urine. Okay? So the glucose causes an osmotic gradient to draw water into the nephron. More water in the nephron means more urine. Okay? If you're putting out lots of urine, that is going to cause your blood volume, or even you can think of it as blood pressure, is going to drop because you're peeing out all of your fluid. If your blood pressure drops, that triggers the release of antidiuretic hormone. Antidiuretic hormone is going to trigger you to feel thirsty. And so, low blood pressure leads to increased antidiuretic hormone. That leads to your patient feeling thirsty. Okay? Last element here is the polyphagia. Polyphagia means excessive hunger and excessive food consumption. And the reason for this is because in diabetes, we have our cells, and here's our bloodstream, okay? And in the bloodstream, we have lots of yummy glucose. However, this glucose cannot get into the cells. And so these cells are going to start to feel hungry. They're not getting the glucose that they require because there's no insulin around. And so as these cells get hungry, they're going to tell the body, hey, you need to eat more, you need to eat more food, you need more glucose because we don't have enough energy. And so that's what's going to trigger the body to have more hunger and more food consumption. Okay? Okay, now, can you tell me, what are the 3 signs of diabetes and why do they happen? Good, excellent. And so just polyuria, you can just tell me about polyuria. Why does polyuria happen? Good. No, you're absolutely on the right track here, Natalia. So because we have so much glucose in the nephron of the kidney, that glucose is going to draw water into the nephron. And the nephron space, that's where all the urine comes from, right? And so if you're drawing water into that space, that's going to mean that you have more urine production. All right, excellent, very good. And so eventually, the body is going to start using fats for cellular fuel, leading to lipidemia, and that can, if severe, lead to ketones, and that gets us into our DKA, or diabetic ketoacidosis. In diabetic ketoacidosis, our body has no more glucose stores. Our cells cannot use any of the glucose that's available, and so it starts breaking down fats into ketones. And ketones will provide a quick source of energy. However, it's going to cause a lot of problems in the blood. Number one, you have lots of acid floating around now. And acid causes big problems for your proteins and your enzymes to working. Your pH starts to fall. It's not a good thing. Untreated ketoacidosis leads to hyperpnea. I don't know. I've always heard this as tachypnea, right? Breathing very fast. Your patient is going to be taking deep, deep breaths, trying to get rid of some of that acid. Disrupted heart activity, depression of nervous system, coma, and death are possible with diabetic ketoacidosis. And so that's a big, big problem. And so if you ever have a patient with diabetic ketoacidosis, the treatment is you just want to give this patient insulin. Okay? We're going to replace their insulin levels, get some of the glucose that's in the blood into the cells, and prevent them from making more ketones. Okay? Great. Now, if you ever have a patient with maybe an insulin-secreting tumor, an insulinoma, this is much different from diabetes. In this case, we have too much insulin. And so this is going to lead to hypoglycemia, which leads to disorientation and unconsciousness. And one good rule of thumb, Natalia, is one of the things that we worry about with patients is hypoglycemia. We worry when patients' blood sugar gets too low. That can lead to death. However, hyperglycemia is not as worrying for us. Yes, if you have high blood glucose, you can start to have these polyuria, polydipsia, polyphagia, but hypoglycemia is actually life-threatening. And so if you have 2 patients, one is hyperglycemic and one is hypoglycemic, the hypoglycemic is the one you're more worried about. Okay, does that make sense? Okay, great. And so some of the symptoms of diabetes, you can look at each organ tissue being involved and sort of seeing what that looks like. So in adipose tissue and muscle, you have decreased glucose uptake, you get glycogenolysis in the liver, protein breakdown, and gluconeogenesis in the liver and muscle. In fats and liver, you have the breakdown of fats, which is lipolysis, and ketogenesis, which is the generation of ketones from fats. Okay, that's what leads to ketoacidosis. You can see some acetone breath. The smell of your patient's breath is going to smell almost like nail polish remover, right? It has a very strong smell. Rapid breathing, nausea, cardiac abnormalities, and can ultimately lead to coma. Any questions on this stuff? No? Okay. So moving on to the next organ system, the ovaries and placenta. The gonads are going to produce our steroid sex hormones, with ovaries producing your estrogen and progesterone. And so each of those are going to have a little bit of a different job. Estrogen in general is going to be important for maturation of the female reproductive organs, appearance of female secondary sexual characteristics, and progesterone causes breast development and cyclic changes in the uterine mucosa. We're talking about menses here, right? And so progesterone is going to be responsible for building up the wall of the uterus in between menstrual cycles. In between the menstrual cycle, you go from, at the start of the menstrual cycle, this is where all the bleeding happens, all of the lining of the uterus comes off. And then in between that period and then the next menses, progesterone is causing growth of the uterine wall. And so after, if conception does not take place, the uterine wall will be sloughed off again and result in another menstrual cycle. Okay. For testes are going to produce testosterone. Testosterone initiates maturation of the male reproductive organs. You get your male secondary sex characteristics. It increases your sex drive. It's necessary for normal sperm production. You got to have some testosterone. And it's going to maintain reproductive organs in their functional states. So males are really reliant on testosterone. One of the big problems is that, sometimes men think they need more testosterone than they actually need. That ends up causing atrophy of the testes. They shrink down and they stop producing their own testosterone. And so that can be a big problem, for the bodybuilders and guys like this that are injecting themselves with testosterone. They get big problems. Okay. Other hormone-producing structures, we talked about atrial natriuretic peptide. So this is released by the atria of the heart in response to increased stretch. So when the atrium stretches, it starts to feel like, okay, I think my blood volume is too high. And so what I want to do is I want to reduce the blood pressure, reduce the blood volume, and reduce the sodium concentration. In doing those things, that's going to reduce the amount of stretch in the atria. Okay, and so that is the purpose of atrial natriuretic peptide. I really like this hormone because it's very straightforward. It's released in response to stretch, and everything it does decreases the stretch. It's a very straightforward hormone, right? We talked about gastrin, secretin, cholecystokinin when we were in our GI tractor, so we're not going to talk about that right now. The kidneys release a hormone called erythropoietin. You may have heard of this as EPO. And this is going to signal the production of red blood cells from the bone marrow. EPO is released whenever there's low oxygen in the blood. Okay, and so when you have a patient who is a hiker, a climber, decides to go climb the Andes and is up in the Andes with very low oxygen that he's breathing in, that patient's kidneys are going to be releasing EPO in a great amount because EPO is going to increase the number of red blood cells. And so even though there's less oxygen, there's more red blood cells to carry the limited amount of oxygen, and so your patient does not get hypoxic. Okay. Next is renin, which is of course the trigger for the entire RAAS system, which we're going to talk about when we meet again on Monday. You're going to tell me all about the RAS system. I cannot wait. I'm so excited. Okay. The skin is really our biggest endocrine organ, if you think about it, because it can produce the precursor of vitamin D. And this is why, we go outside, we bathe in the sun, you say, oh, I'm getting my vitamin D. This is why. When the sun rays hit the skin, there's enzymes that can convert that photonic energy and use it as an enzyme to create cholecalciferol, which will ultimately go on to become vitamin D. Vitamin D will go on to increase our levels of calcium in the blood. Okay, so vitamin D is a very important vitamin as well as hormone. Last is our leptin, coming from adipose tissue, which is involved with appetite control. Leptin is going to decrease our appetite. Okay, that's the beautiful thing about leptin. If you have a lot of leptin, it is going to decrease your appetite. Ghrelin is another hormone that's not listed here. Ghrelin is a hormone that increases your appetite. Okay, and so when you think about, trying to be on a diet, you're trying to eat good, and then you see that, those hot, fresh chocolate chip cookies, and then you have that gremlin on your shoulder, That saying, go eat those cookies even though you're on a diet, that's ghrelin. The ghrelin gremlin is telling you to eat those cookies, whereas leptin is trying to keep you skinny, okay? Leptin is involved with appetite control. Okay? Great. So, we have a question for you here, Natalia. In a patient with a genetic defect in growth hormone receptors, making them partially unresponsive, you would expect hormone of IGF to be higher than normal, lower than normal, or normal. Good, good. And why is that? Good, good. Okay, so growth hormone is going to trigger an increase in IGF, right? Okay, good. And so if you don't have growth hormone receptors working properly, you have lower than normal IGF. You should expect your patient to be shorter in stature and have difficulty sort of growing vertically, essentially. Okay, great. And so exercise causes an increase in growth hormone secretion, sort of a benefit of exercise. After the finish of exercise, homeostasis would be restored because the circulating growth hormone releasing hormone would increase, decrease, or not change. So just thinking about our axis here. So we have our hypothalamus here with our growth hormone releasing hormone. This is going to increase levels of release of growth hormone from the anterior pituitary. Here's our anterior pituitary, here's our hypothalamus. And growth hormone is going to go on to have its effects. Growth hormone is also going to have a negative feedback at growth hormone releasing hormone. And so if exercise causes an increase in growth hormone secretion, when growth hormone increases, you can expect to have decrease in levels of growth hormone releasing hormone. Okay? Great. Okay. And so I just have to step away for just 5 minutes, okay? I will be right back, Natalia, but work on this question until I come back, okay? Okay. Thank you. Luna, tell you? So sorry about that. We didn't have a babysitter tonight, and the baby was crying, so I was just checking on her. But good. So, what did you think about this question about the medical student volunteering on a research project? Hello? Oh, you're thinking? Okay, that's okay. And so here, what we can look at is we have to compare these different types of feedback mechanisms, right? And so we know that there is a negative feedback involved with growth hormone, right? You know, there's that growth hormone releasing hormone we just talked about, and that is going to be negatively influenced. It's going to positively influence growth hormone, but then growth hormone is going to come back and reduce growth hormone releasing hormone. However, it doesn't say anything about growth hormone releasing hormone or that whole axis, right? It doesn't tell us that growth hormone releasing hormone is high or low or what. All it says is that we're taking blood samples at midnight and noon, and that it's higher at midnight than noon. And so this shouldn't have anything to do with negative feedback. It should have something to do with that time of day, right? So so positive feedback wouldn't be related to it either. Stress related, exercise related, or circadian. That's what we're kind of left with. Now, good, yes, circadian. And so we can say that it's probably not exercise related because most people don't exercise at midnight, right? And so that should not make your growth hormone levels high. Maybe you do, you know, maybe that's your thing to do. But yeah, so good. So circadian is the way that growth hormone is going to be changing levels throughout the nighttime. Okay, very good. Next, we have a 4'11", 17-year-old male tested for a growth hormone disorder. Is found to have elevated growth hormone releasing hormone, elevated growth hormone, but normal thyroid function. His most likely disorder is, okay, and so we're left with a few options here, and these are all forms of dwarfism, essentially, or forms of a abnormality that cause a person not to reach a full height. Okay, so achondroplasia. This is going to be a defect in one of the proteins responsible for making cartilage, and that defect is in the FGFR3 gene. Okay, FGFR3, and that ultimately leads to certain parts of the growth plates not extending properly. And a lot of times these patients, they will have a normal appearing face. However, their body should seem a bit smaller than normal. Okay, did you ever watch Game of Thrones? You know Tyrion Lannister? So that actor has achondroplasia. That's what he has. And so when you think of achondroplasia, think about this FGFR3 mutation related to cartilage formation, and that is what leads to that diminished size. However, has nothing to do with growth hormone, nothing to do with growth hormone releasing hormone, so we can take that out here. Okay? Pituitary dwarfism. Now, pituitary dwarfism means that our hypothalamus is fine. Here's our hypothalamus. Hypothalamus is fine. It's releasing growth hormone releasing hormone. However, in our anterior pituitary is not releasing anything. So here's our anterior pituitary, and there's no growth hormone being released. This would ultimately result in dwarfism because the patient is not having any growth hormone to stimulate that IGF and stimulate bone growth. However, they've told us in the question that he has elevated growth hormone. Okay, and so we can assume that the pituitary dwarfism is not the case. Okay, skipping Laurent dwarfism for now. Cretinism is when your patient does not have enough thyroid hormone from a young age. They ultimately do not reach their full height as well. That's cretinism. However, they told us there's a normal thyroid function, and so we can take that out, and that leaves us with Laurent dwarfism. So Laurent dwarfism is when you have a defect in your IGF receptor. A defect in your IGF receptor. As we talked about before, growth hormone is going to go on to stimulate Growth hormone is going to go on to the liver. Here's our liver. It's a very beautiful liver. Liver is going to produce our IGF. Okay? IGF goes on to increase the size of our bones. This is a bone. And increase the size of our muscles. Okay? However, that requires IGF to bind to IGF receptors on the bone. Here's a little IGF receptor. If IGF cannot bind this receptor, that means the bones are not going to grow. Even though we have plenty of IGF in the blood, the IGF cannot bind its receptor. Okay? So that kind of explains why this patient is only 4'11". However, why is the growth hormone and growth hormone releasing hormone high? Well, when we talked about IGF, we said that there's a negative feedback on the anterior pituitary and a negative feedback at the hypothalamus. In order to have that negative feedback, IGF has to bind to its receptor in each of those places. Okay? In this particular problem called Laurent dwarfism, we just said that IGF cannot bind its receptor. And so in the hypothalamus and in the pituitary, IGF is not able to give that negative feedback, and so you still have an elevation of your GHRH and an elevation of your GH, even though you have normal levels of IGF in your blood. The problem is it can't bind to its receptor. Great. Any questions on that one? No? Okay. Great. So that is the end of our first endocrine lecture, and I will go ahead and open up our second one here. Endocrine 2. Okay, you can see my screen okay? Great. So endocrine 2, we're going to start with the adrenal gland. We talked last time about the layers of the adrenal gland. We said salt, sugar, sex, and then the adrenal medulla inside. And so when we were going through this, maybe you remember one thing I mentioned is that on step 1, you may get a picture where you need to identify the layers, okay? And this is the picture I'm talking about. I had a picture just like this on my step 1 exam. And so if they give you this, they should tell you that it's the adrenal gland, and then they're going to ask you, okay, where does cortisone come from? Okay, and so with cortisone, you should think, okay, that's related to cortisol. Cortisol is my hormone that elevates sugar. Sugar is the second layer, so I'm going to pick this area here, the second layer of the adrenal gland. Do you feel pretty comfortable with that? Like you would be able to identify the layers if they gave that to you? Okay, good. Good, that's good to hear. So we mentioned before that aldosterone is coming from that glomerulosa. Triggers for that, angiotensin II and elevated potassium. From the fasciculata, hormone being released as cortisol, which is stimulated by ACTH. From the reticularis, we have androgens, our sex hormones, being released, and that is also partially stimulated by ACTH as well. Okay, great. So the steroid hormone pathway, you know it was coming, right? You knew this was coming. And so here it is. We have to have some understanding of the synthesis of steroid hormones so that when we start to talk about pathologies, we understand why those pathologies are there. And so all steroid hormones start out as cholesterol. From that cholesterol, we're going to go down a few different routes to ultimately create our aldosterone, to ultimately create our cortisol, and to ultimately create our sex hormones. So each of these, as you can see, represents a different layer of the adrenal gland. We have our glomerulosa here, we have our fasciculata and reticularis. And as we're going through these layers of the adrenal gland, what you'll notice is there are some enzymes that are present in the deeper layers that are not in the other layers. So for example, in the glomerulosa layer, you have all of the enzymes to the left of this line. Okay, all the enzymes over here are present in the glomerulosa layer. And so in the glomerulosa layer, the only thing you can make is aldosterone, because what you have is 3 beta, 21, 11 beta, and 18. If you have these 4 enzymes, then you can make this hormone. As we move to the fasciculata layer, all the enzymes we have are the enzymes that are left to the line again. And so here we're adding in 17 alpha. We have this 17 alpha as well as 3 beta, as well as 21, as well as 11 beta. And if you have this combination of hormones, of enzymes, you can make cortisol. Last, in the reticularis layer, you have all the enzymes to the left of this line. And so we have our 1720, we have our 3 beta, 17 beta, and 5 alpha. That makes our sex hormones. Okay, so great. So now, if we have some sort of deficiency or some sort of lack of one of these enzymes, use this understanding to inform what you think is going to go wrong. For example, let's say I take away this 21 enzyme, right? This is a 21 hydroxylase is the name of this enzyme. Let's just delete it from our patient's genetic code. So now, when cholesterol is going down to become pregnenolone, going down to become progesterone, now it can't go any further. It cannot progress any further, right? There's a red line here. And so its only option is to go right. Okay, so 17 alpha is going to convert it from progesterone into 17 hydroxyprogesterone. Now it's going to try and go down to create cortisol. However, we're missing 21, we said. So because it cannot go down this way, it's going to be converted from 17 hydroxyprogesterone to androstenedione. And now that it's androstenedione, it's going to become testosterone. Okay? And so in patients that are missing the 21 hydroxylase enzyme, that are missing this enzyme, those patients have extra sex hormones. And so you can expect that these patients are going to present with early masculinization, with early chest hair and armpit hair in young boys, or masculinization of the genitalia in newborn girls. These are the things we're going to see because they cannot create cortisol. The body wants to make cortisol, but every time it tries to make cortisol, all it makes is testosterone. Okay, does that make sense? Yeah? Okay, so good. So I'm going to explain it again, but I'm going to use a different enzyme this time. Okay? So let's, instead of saying 21, let's pretend that we lose, let's see, let's pretend that we lose this enzyme, 17 alpha. Okay, so we lose this enzyme and we lose this enzyme. You cannot pass here. Okay, so our body says, I want to make some cortisol, or I want to make some testosterone. So cholesterol comes down this pathway, it gets turned into pregnenolone, it tries to cross over to become 17-hydroxypregnenolone. However, it cannot pass. And it says, okay, well, if I can't go that way, I'm going to progress downwards, down this pathway to progesterone, and then try and become cortisol this way. Oh, still cannot pass. We are missing our 17 alpha. And so while the body's trying to make cortisol, it ends up pushing all the cholesterol into making aldosterone. And so in patients that are missing a 17 alpha hydroxylase enzyme, those patients have extra aldosterone. If you have extra aldosterone, that is going to lead to increased salt retention, right? That's what aldosterone does. It causes us to retain salt. You're going to have a decreased potassium because aldosterone causes us to drop the level of potassium. Salt or water always follows salt, and so because of this, you're going to end up with elevated blood pressure, and that's how those patients are going to look. Whenever you have a 17 alpha hydroxylase deficiency, you have elevated blood pressure because you're retaining salt. Okay, does that make sense? Good. And so in terms of understanding the steroid hormone pathway, you're going to get questions on it, right? The 3 enzymes that they can possibly ask you about are this 21, which we already talked about. If you knock this out, then you cannot make these 2 hormones. All that you make is testosterone. That's for 21. The next one that they will ask you about is your 17. If you knock out 17, then you cannot make cortisol and you cannot make your sex hormones. So all you're left with is aldosterone, leading to elevated blood pressure. And the last one that they will ask you about is this 11 beta knockout. If you knock out this 11 beta, you cannot make aldosterone and you cannot make cortisol. okay, if you knock this out. However, so most of your hormones end up becoming testosterone. However, there's one caveat or one special thing about an 11 beta deficiency, which is that this intermediate deoxycorticosterone, notice there's no arrow for it to go over this way. As cholesterol comes down this direction, it gets trapped as deoxycorticosterone. It cannot go on to create testosterone. There's no arrow there. And so what ends up happening is this deoxycorticosterone actually has some ability to bind to aldosterone receptors. And so when you have an 11 beta deficiency, you see an increase in your sex hormones, and you also will see an increase in your salt and a decrease in your potassium. Increased salt and decreased potassium. Why? Because this deoxycorticosterone, it looks like aldosterone enough that it will bind some of those aldosterone receptors. And so look for a patient with elevated blood pressure in a 11 beta deficiency as well. Okay? Is this clear? We have questions on this later, so if you have any questions, please don't hesitate to ask now. Okay. Yeah, and it helps when you're actually staring at it, right? You know, you're not going to be able to recreate this entire chart when you take your step 1 exam. When you take your step 1 exam, what I would like you to do is write cholesterol, okay? And then draw a line down, draw a line down, draw a line down, and then I want you to write your 11 beta here, and then draw a line down, and then I want you to write aldosterone. Okay? And then from your cholesterol, you're going to draw a line across, a line across, a line down. You're going to write 11 beta here, and then you're going to write cortisol. Okay? And then you're going to draw a line across like this, and then you're going to draw a line down, and you're going to write androgens. Okay? Okay, and so the only thing to fill in left is going to be your 21, and your 17. Okay, so this is sort of your quick way to draw out that chart without having to actually draw out the chart, okay? And so the important thing that you understand here is knocking out 17 would lead you to have elevated aldosterone, knocking out 21 would lead you to have elevated androgens, knocking out 11 beta would cause you to have elevated androgens and some effects of elevated aldosterone, meaning some high blood pressure. Okay? Great. And so here is the diagram from your first aid book. If you prefer this one, that's fine too. I think the other one is a little bit more clear. This one looks a little bit busy, but you can see the same thing is happening here. So here is our cholesterol trying to become aldosterone, our cholesterol trying to become cortisol, and our cholesterol trying to become our testosterone and ultimately our estradiol and the other sex hormones. And so as cholesterol is trying to make its way down these pathways, if you say block it off with the 21 hydroxylase deficiency, if you lose this enzyme, that means that everything cholesterol is going to be going to become sex hormones. If you instead block off this part of the pathway, your 17 hydroxylase, all of the cholesterol is going down to become aldosterone. If you block off this 11 beta, that means you're losing your aldosterone, you're losing your cortisol, but we said 11 deoxycorticosterone can bind to some aldosterone receptors, and so you still see elevated blood pressure in this case. Okay? Okay, great. And so these are what we call the congenital adrenal hyperplasias, where the body will be trying to make cortisol. However, because of these missing enzymes, it cannot, and you end up with high levels of other enzymes that you really don't want. Okay, great. So in general, what is the point of cortisol? We've really talked about it quite a bit already, but we said that cortisol in the early fasting state is going to increase the synthesis of glucose. It activates some of the anti-inflammatory pathways, and really the whole goal is to increase the blood glucose. Okay. If the cortisol is elevated for a long time, it leads to breakdown of proteins and muscle wasting. Okay. Cortisol is going to counteract insulin. It's going to raise blood glucose, and so that's another thing we have to keep in mind. In terms of the immune system, cortisol is going to dampen the immune system and ultimately cause your patient to be more susceptible to infections. This is a lot of words and a lot of detail, but what I'd like you to know, Natalia, is that whenever you have high cortisol, the immune system is going to be decreased. You have a weaker immune system. Okay? And last, enzyme activity. Cortisol is going to stimulate copper enzymes, and if you think about the important copper enzymes in the body, one of the most important ones are the copper enzymes involved with cross-linking collagen, right? And so when you synthesize collagen, there's a really nice diagram of this in your Step 1 book, but when you attempt to synthesize collagen, in order to make nice, strong collagen, you have to cross-link it. What enzyme cross-links it? Well, it's a copper enzyme called lysyl oxidase. And if you hyperactivate that enzyme, you're going to end up having breakdown of the collagen in the skin. And so this is why in your patients with Cushing's disorder, why you see those striae or you see those lines in the patient's skin, because you're having increased breakdown of the skin because of these copper enzymes. Okay? Great. Going on to aldosterone. Aldosterone is essential for life. Without aldosterone, you're going to have drops in your blood pressure, ultimately leading to circulatory shock. Aldosterone is going to increase transcription of genes at the nucleus. We said any steroid hormone always crosses right into the cell and induces their changes at the level of the DNA. Some of those changes involve inserting a sodium channel as well as a sodium-potassium pump. But the overall effect, and what I really want you to know, Natalia, is increased sodium retention and wasting of potassium. More potassium leaves the body. Overall, this causes an increase in blood pressure. Okay, so moving right into the pituitary, we're going to talk about our adenomas, our hyperfunctioning and hypofunctioning. We'll talk about prolactinemia. Prolactin is that hormone that's necessary for milk production. What happens when it gets too high? Acromegaly, increase of the size of the head. You already told me all about that in growth hormone. We're going to talk about it again, diabetes insipidus, as well as Cushing's syndrome. So let's get right into it. So here is what a pituitary adenoma looks like on MRI. You can see here is our pons. Here is the cerebellum. Here is the corpus callosum. Here's a ventricle. And this little dinky thing hanging off into the brain is what we call the pituitary. Now, in this pituitary, it has actually increased in size and is secreting hormones. This is what we call an adenoma. When an organ increases in size and starts secreting a hormone, we call it an adenoma. These are going to be sporadic. They happen here, there, everywhere. There's not really some genetic predisposition. They just tend to happen. They usually manifest in adults, and the mutation is a GNAS mutation that leads to this particular condition. You may see mass effect, meaning you may see pressing of this tumor on some of the other structures around. And so the sella turcica is the bone in which the pituitary sits. So here's our pituitary, kind of this dinky thing hanging off, and this is what we call the sella turcica. As the pituitary starts to enlarge, it's going to erode the bone here. Okay, it's going to break down the bone that is supposed to be encasing it. As the pituitary grows, right above the pituitary, we have our visual nerves. Right? Our visual nerves cross right above the pituitary. And so as the pituitary grows, it's going to start to compress on the visual nerves, giving us visual problems. This will lead also to an increase in the intracranial pressure, leading to headaches for your patient, leading to papilledema when you look at the retina of your patients. And if the pituitary gets too large, some of the vessels can start to bleed. And so, as your pituitary is getting larger, these vessels that are growing inside of it, they're weak vessels. They're not good vessels because these are tumor vessels. And so these vessels can start to bleed into the pituitary, causing necrosis and death of the pituitary. Okay? Great. And so, why do some of these tumors cause mass effect? Well, this gets us into the difference between a functional adenoma, which is an adenoma that makes hormone, and a non-functional adenoma. A non-functional adenoma does not make hormone. All it does is grow. And so your patients really are not going to know that they have a tumor at all, because they just have something growing in their head. And if I had something growing in my head right now, I probably wouldn't know until it starts to get large. Once it starts to get large and in charge, it's going to start pressing on my visual nerves and causing me to lose vision. It's going to start causing me to have headaches and increase intracranial pressure. And so in non-functional adenomas, they tend to cause symptoms like visual loss as well as intracranial pressure leading to headaches. However, functional adenomas, those adenomas that synthesize a hormone, those adenomas are usually small, okay? Because those patients are going to present to your office before they get large. Why do they present? Well, these tumors are secreting, say, prolactin. If you have a man who has a prolactin secreting tumor in his brain, he's going to have enlargement of his breast tissue. He's going to have a decrease in his libido. This man is not going to be happy, okay? And so even though the tumor is quite small, he's going to come into your office, okay? And so this is the difference. When you have a functional adenoma, it causes other symptoms for your patient. The hormones are causing symptoms, versus a non-functional adenoma does not cause those same symptoms until it's very, very large. Okay? Okay, great. So hypopituitarism, or low levels of pituitary hormones. The most common cause is a non-functional adenoma, like in the one in the previous slide. Another cause would be surgery or radiation. If your patient had some sort of surgery in the past or needed radiation for some kind of cancer, that can cause a decrease in your pituitary enzymes. Wow, I cannot stop writing. Hold on a second. What is this? Okay, great. So apoplexy and insufficient blood supply. We talked about those weak vessels growing into a tumor. And last is going to be Sheehan syndrome. And Sheehan syndrome is when during pregnancy, the pituitary grows. A pregnant woman needs more hormones than a non-pregnant woman. And so while a woman is pregnant, her pituitary is going to grow in size. That's normal. Every pregnant woman this happens to. The problem is, if that woman with this big pituitary gland that needs a lot of blood supply, if that woman loses a lot of blood during childbirth, that pituitary is not going to get the oxygen and blood supply it needs to survive. And this is going to end up causing destruction of part of the pituitary gland, and we call this Sheehan syndrome. These patients are going to present because they don't get their menstrual cycle. They already gave birth, it's been 6 months, and they're still not having their menstrual cycle. So why don't these patients have their menstrual cycle? Good. Yes. Yes, very good. So LH is a very important part of the menstrual cycle, as is FSH. So you need both of those to have a menstrual cycle. If they're not menstruating, that means they lost those two hormones. Very good. Very good. What about the hypothyroidism? Why do these patients get hypothyroidism? TSH. TSH. So TRH is made by the hypothalamus. TRH levels will probably be pretty high in these patients because their TSH is going to be gone. TSH is the one that's released by the pituitary and goes on to stimulate the thyroid to produce T3 and T4. But yeah, so great. And last is our adrenal cortical deficiency. And so this is referring to our levels of cortisol being low. Okay, and so the reason our cortisol is low is because we're missing which hormone? So, thinking about the pituitary, hormones we've talked about. We've talked about our growth hormone, TSH. We talked about LH, FSH. We talked about prolactin, and then there's one more that goes to the adrenal glands to stimulate the adrenal glands, okay? And it has a C in it for cortisol. Not sure? That's okay. So this is going to be our ACTH. Yeah. So that's going to be our adrenal cortical T hormone. I don't know what the T stands for, but just remember this C stands for cortisol, and so it's going to the adrenal glands to increase cortisol. Okay. Excellent. Very good. So that's our Sheehan syndrome. Hyperpituitarism means we have a functional adenoma. Again, these patients, the tumor may be very small, but they're coming in because they're already having symptoms. Will there be local mass effect? Typically, no. These patients are coming in because they have hormone secretion. By the time a adenoma gets to the size where it causes mass effect, that amount of hormone would be lethal. And so patients usually don't wait that long before coming into the emergency department. The most common type of pituitary tumor is prolactinoma. This is a question on your step 1 exam. The most common type of tumor in your pituitary is a tumor that secretes prolactin, okay? And so in women, that is going to lead to amenorrhea, galactorrhea, and infertility. In men, this is going to lead to decreased body and facial hair, as well as a decrease in the libido. Woo! Right? Not good. And so just remember, prolactin brings on female characteristics. And so this is what we look for in men. In women, look for lack of the menstrual cycle. Look for stimulation of the glands, the milk glands. Okay. A growth hormone producing adenoma, it's a little more rare, but we can still talk about it. In children, it leads to gigantism. In adults, like you told me before, we get acromegaly. And so here it's really just growth of the skull bones and the hand bones, okay? So hats don't fit and the gloves don't fit. That's what acromegaly looks like. Growth hormone stimulates hepatic secretion of IGF-1. And to test this, what we do is we give a glucose load orally, and when you give glucose, you should see growth hormone go down. However, in a patient with a growth hormone producing adenoma, growth hormone stays high. Okay? Great. So looking at our acromegaly, we talk about how you have that thickened calvaria, those thickened bones of the skull, increase in size of some of the facial bones. You may see a goiter, some thoracic vertebrae abnormalities, increase of the size of the heart, a barrel chest, sexual dysfunction, increased size of the hands and feet, we said, arthritis, and then some peripheral neuropathy is common to see in these patients as well. Okay, that's our acromegaly from a growth hormone secreting tumor. An ACTH producing adenoma is going to increase levels of what hormone? Cortisol. Excellent. So increased levels of cortisol is going to lead to your Cushing's syndrome. Okay? Having cortisol that is too high for too long leads to Cushing's syndrome. Now, you can have a Cushing's syndrome that's due to your patient taking too much prednisone, right? They can be taking too many glucocorticoids. Say you gave your patient some steroids to treat their lupus, right? You give them steroids for lupus, they stay on those steroids for a year, and now they have Cushing's syndrome. Okay, that's a Cushing's syndrome because they have too many steroids for too long. However, you can also have Cushing's syndrome when you have this ACTH producing adenoma. ACTH is going to stimulate an increase in cortisol, and that is going to lead to all of the symptoms of Cushing's syndrome, just the same as if you had a patient taking those pills of steroids. Okay, so whether it's exogenous, they're taking the pills of steroids and it's causing Cushing's syndrome, or they have a tumor that's increasing their cortisol and causing Cushing's syndrome, it's all Cushing's syndrome. Okay. However, if it is due to a ACTH producing adenoma, it gets a special name and we call it Cushing's disease, okay? And so you see all of the manifestations, all of the symptoms of Cushing's syndrome, but because it's due to this adenoma in the pituitary, we call it Cushing's disease, okay? It's just sort of one of those funny things that as you go through questions, you may see answer choices where it says A, Cushing's syndrome, and B, Cushing's disease, and you're like, whoa, 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 I thought these were the same thing. I'm telling you right now, the only time you get to call it Cushing's disease is if you have one of these things, an ACTH-producing adenoma, right? Because there's a lot of ways to get Cushing's syndrome. You can be taking pills of prednisone or glucocorticoids to get Cushing's syndrome. You can have a tumor in the adrenal gland. Adrenal tumor. An adrenal tumor will elevate the levels of cortisol as well. However, that would be a Cushing's syndrome still. The only way to get Cushing's disease is to have an ACTH-producing adenoma. Okay? Great. So how about the posterior pituitary? We've been talking so much about the anterior. What about the posterior? Let's not forget about that one. So if we have damage to the posterior pituitary, this causes diabetes insipidus because we lose our antidiuretic hormone. If we lose our antidiuretic hormone, our patient is going to pee. And you told me all about that last time we met. Most common cause here is going to be head trauma. Tumors can happen as well, inflammatory diseases, surgical complications, but most commonly I'd like you to associate it with head trauma. Okay? We test this with the water deprivation test and look for the urine's concentrating ability. The urine will not become more concentrated over time, but if you give an exogenous antidiuretic hormone, we call this desmopressin, right? If we give desmopressin will cause concentration of urine. Okay, that will concentrate the urine. Okay, great. So that causes concentration of the urine. That's our diabetes insipidus. Now, the thyroid gland. My opinion on the thyroid gland is that it always loves to cause problems. Have you ever met someone and they said to you, man, my thyroid is amazing. I love my thyroid. It's so good. My thyroid is just, I love it. No, because people only ever have hypothyroidism, hyperthyroidism, thyroid tumors, Graves' disease, right? Like no one has a really great thyroid. People only complain about their thyroids. If I were to be God for a day, I would just snap my fingers and make it so no one needs thyroids because it really only causes problems, okay? But anyway, I get very passionate when I talk about the thyroid gland. I hate it, okay? I love my thyroid gland, okay? Don't quit on me now. So great. So let's talk about all the thyroid pathology. Graves' disease, autoimmune. Hashimoto's, autoimmune. De Quervain's disease, Rydell's disease, and then we have our tumors, which we remember with MFAP, medullary, follicular, anaplastic, and papillary. Okay, so here we have a picture of a normal thyroid tissue, normal thyroid biopsy. If we, as we go through these, we're going to see some pictures of some abnormal thyroids, and so I wanted to include this so that, as we move forward, you have something to compare it to. Okay. Great. So thyroid hormone, important. Growth, sexual maturation, brain development, like you told me before, during the fetal period, as well as the early childhood. What happens if there's a deficiency in TSH? Well, we end up with cretinism. Our children are not going to grow vertically, like we said before, and they are also not going to mature mentally. Okay, so that's a big problem. Hyperthyroidism causes a number of symptoms that we need to be aware of. So think about whenever you increase your basal metabolic rate. I know we just kind of reviewed this, but increasing your basal metabolic rate is going to have a number of effects. So starting at the bottom here, a tremor. These patients' hands, think about if you increased your metabolism. Oh my God, it's like you drank 20 cups of coffee. Irregular menses, weight loss, tachycardia, sweating. The size of the thyroid can grow, giving you a goiter. Exophthalmos, fine hair, muscle wasting. All of these symptoms can be seen in hyperthyroidism. And our classic example of hyperthyroidism is going to be Graves' disease. And so let's talk about Graves' disease. We said this is an autoimmune disease. It's autoimmune, and so in terms of our patient population, we're really thinking about young adult females. These are the people that tend to get autoimmune diseases. I'm sorry to say that. So young adult females, what ends up happening is that our body starts producing antibodies, IgG antibodies. And these are a special kind of antibody. They're not going around and destroying things. They're not going around causing inflammation. What they're doing is very sneaky and very rude. This is our thyroid gland. All right, our thyroid gland has receptors on it for TSH. TSH is coming down from the anterior pituitary, and it's going to bind to that receptor and cause the thyroid to release T3 and T4. Okay, that's the way that the thyroid normally works. In Graves' disease, what happens is we have development of these antibodies, autoantibodies. Okay, this is an antibody. And this is a very sneaky antibody. What it does is it comes in and it pretends to be TSH. So it sneaks in here and it binds this receptor. So now levels of T3 and T4 increase. And so this is going to go back and cause a negative feedback to the anterior pituitary and say, hey, we don't need any more TSH. You can stop making TSH. However, we still have antibodies binding to this receptor. T3 and T4 increase. More antibodies bind to more receptors, more T3 and T4. And you end up with a situation where you have very high thyroid hormone, but you have very low thyroid stimulating hormone. Your TSH should be low. Okay? On pathology, if you do a biopsy, you see hyperplasia of the follicles, some moth-eaten colloid at the margins. What does that look like? Here you can see it looks like, compared to our normal thyroid, we have more cells in between the follicles, right? And then if you look at the follicles themselves, they have these big white gaps on the edges. So these big white gaps are where these cells of the thyroid gland are rapidly eating up all of the colloid inside. They're being super stimulated by those autoantibodies, and so they're just working overtime trying to create thyroid hormone. I mean, you can see this particular follicle, it doesn't even look like a follicle anymore, right? Follicles are supposed to be round, and this looks like, it kind of looks like a dinosaur almost, but it definitely doesn't look normal. And so these are some of the things we can see with Graves' disease. Okay. Great. So, any questions on Graves' disease, Natalia? Do you have any questions about Graves' disease? No. Okay, good. Next is our hypothyroidism. And so for hypothyroidism, again, we are looking for the opposite of hyperthyroidism. We're slowing down the metabolism. So let's start at the bottom and see what we see. Some peripheral edema. You're going to have some anovulatory cycles where you have these lack of menstruation, constipation, atrophy of the stomach, some cardiomegaly, hoarseness, a large tongue, a pallorous skin, edema in the face, loss of your eyebrows, coarse and brittle hair, and muscle weakness. Okay. In addition to these things, look for weight gain. Look for these patients, whenever they go out into the cold, or even when they go out into a room temperature room, they're going to feel cold because their body has lost the ability to increase its own temperature. And so going into a cold environment is very difficult for these patients. Okay. Hashimoto's is our classic example of hypothyroidism, and it's another autoimmune hypothyroidism. However, in this condition, instead of stimulating the thyroid gland, here we're destroying it, right? The autoimmune process is going to involve direct destruction of the thyroid gland itself. And so we have elevated anti-thyroglobulin antibodies, anti-microsomal antibodies, and TSH receptor blocking antibodies, right? How mean is that? It's even blocking the receptor. Not cool. And so this is seen commonly in women again. Excuse me. Except typically these women are a little bit older that end up with Hashimoto's. Okay. Great. And so on our biopsy, what we see is lots and lots of these dark cells. These are your autoimmune cells, your T cells that are coming in here and just completely destroying your thyroid gland, okay? And so, of course, this is going to lead to decrease in your T3 and T4, decrease T3, decrease T4. However, my question for you, Natalia, is what's going to happen to TSH? Increase, decrease, stay the same. Increase. Good. Yes, because we are destroying our thyroid gland. We lose that negative feedback, and so TSH is going to jump up. Okay? Very good. Our next type of thyroid inflammation is something called subacute granulomatous thyroiditis. You may also hear it called de Quervain, right? As if this name is not fun enough, they gave it a second name. And so, really just breaking down this name, subacute meaning it develops slowly, granulomatous meaning you see granulomas, right? And thyroiditis, inflammation of the thyroid gland. And so let's go to the text here and see what we mean by that. So extensive follicular destruction, we see macrophages, we see foreign body giant cells surrounding the fragments of the colloid. Look for a history of a viral infection. Your patient should have had a viral infection, in the weeks before developing this thyroiditis. These patients typically have a full recovery a few weeks later. And so, when you have this thyroiditis, you're going to see a decrease in your T3 and T4. However, these patients have a full recovery. And that is going to distinguish it from Hashimoto's, where you have a prolonged course, where instead of being acute, Hashimoto's takes a long time to resolve. In Hashimoto's, your patient is going to be sick for maybe 1 year, right? And subacute granulomatous thyroiditis, you can think of maybe 1 month. Okay? And so, subacute granulomatous thyroiditis, it has a much shorter course, and then this thyroiditis is painful. That's a big difference between Hashimoto's. Hashimoto's is not painful. If they're telling you that when you press on this patient's neck that they have acute and pinpoint pain, think about granulomatous thyroiditis. Okay? This is a big helpful hint. I'm going to put a star by this one. If they're telling you in the question stem that your patient is having pain when you press on the thyroid, there's really nothing else it can be. It's got to be this subacute granulomatous thyroiditis, aka de Quervain's thyroiditis. Okay? Great. On biopsy, don't worry about the biopsy for this one. They would never make you identify this one by biopsy, but just for your education and your learning, what we see here is a giant body macrophage, where this is actually a single cell. However, you see lots of nuclei inside. Whenever you have granulomas, macrophages can do this. Okay, macrophages, they can get together, they can, a bunch of macrophages can join together and form one giant cell. And so, because this is a granuloma type condition, that's what we see here. Our last type of thyroiditis, I promise, is our Rydell's. I told you, thyroid, it only causes problems. So our Rydell's thyroiditis is where we have fibrosis of the thyroid, giving it a wood-like consistency. And so they're going to describe when you're pressing on the thyroid, it's not painful, not painful. However, it is going to feel hard when you press on it. It's going to feel like a hard wooden lump when you press on the thyroid. Okay, so that's your Rydell thyroiditis. And, you know, kind of looking at the thyroid gland here, you can barely see the normal thyroid gland tissue. It can't really be recognized. Okay. Great. So that's really all there is to Rydell's thyroiditis. You just need to be able to identify it in the question. That's really all there is to it, Natalia. If they give you a wooden thyroid that's not painful, think about Rydell's. Okay. Great. So now moving into our thyroid tumors. Excuse me. An important concept about testing for thyroid tumors is you can have an active thyroid tumor, a tumor that is creating thyroid hormone, and you can have an inactive thyroid tumor, a tumor that is not creating thyroid hormone. This is a bit like when we talked about our functional and non-functional adenomas of the pituitary. However, we're going to kind of add another layer here when we talk about the thyroid gland. In the thyroid, if you see a nodule that does not create hormone, that is likely to be malignant. It's more likely to be cancer. If you see a nodule that is taking up radioactive iodine, that is creating hormone, it's more likely to be benign, not cancer. Okay? And the reason for this is because benign lesions, these are tumors that still remember who they are. They still remember where they came from, right? This is the Jenny from the block. I used to be a thyroid cell that made hormone, and I'm going to still make hormone. When cells start forgetting where they're from, I don't remember what kind of cell I used to be. I'm just going to go metastasize to some other part of the body. That is a cancer. That's a cell that you need to be worried about, okay? And so it's really about this level of differentiation. They're still doing their job as thyroid cells. Malignant cells don't care about iodine. They're busy being cancerous. So let's start talking about our thyroid tumors. The tumors we said are MFAP, MFAP. So this is our F, our follicular adenoma. This is going to be an encapsulated follicular lesion. It's usually quite small, 3 centimeters, not too big. And the follicles will be of variable size. Typically, the genetic mutation involves the TSH receptor, and ultimately you're going to have compression of the thyroid leading to hyperthyroidism. Okay, so for follicular adenoma, think about hyperthyroidism. One important point about follicular adenoma is you want to see that there's a nice border. Okay, and so you can see above that line, here's our normal thyroid tissue. Here is the edge of the follicle, and here is the follicle itself. So the follicular adenoma is down in this area, and we have a nice border, and then we have normal thyroid tissue above, okay? And again, I want to stress seeing a nice border is important because that's going to differentiate a benign lesion from a cancerous lesion, okay? Next, from our MFAP, is our papillary carcinoma. This is the fun one. Not fun for people that get it, but fun for us in terms of learning thyroid tumors. It's our most common type of thyroid cancer, meaning you're going to get the most questions on papillary carcinoma. Look for a history of radiation to the neck. The gain of function mutation is RET. This is the one that I'd like you to know for the USMLE exam. A gain of function in RET is the most common mutation. When you look at the biopsy, what you see is a ground glass appearance of the nuclei. They call these orphan Annie eyes, which is just so silly, but if you look at some of these nuclei, say take these nuclei here, you can see that the cytoplasm looks very clear, and then you end up with these 2 nuclei inside of it, kind of looking like eyeballs looking up at you. And I don't have a better picture than that, but this is going to be your papillary carcinoma. And I think you can agree with me that this looks a lot different from your normal thyroid tissue. There's a lot of this clear, fat in between, or cells, whatever this is. There's a lot of stuff in between these cells. And then the cells themselves have that clear cytoplasm. And so that is consistent with, those are your orphan Annie eyes, okay? The other thing you can see is psammoma bodies. And so psammoma bodies are what you're looking at right here. They're dark concentrations of protein that collect inside of certain types of tumors. And so those are the 2 things you look for, orphan Annie eyes and psammoma bodies. The way that you remember papillary carcinoma is you say, little orphan Annie wanted a mama for psammoma bodies and a papa for papillary carcinoma. How helpful is that? Oh my goodness. Little orphan Annie. What's that? Creative? I'm telling you, I have the stupidest ways of remembering things, but they work. I promise you, Natalia, they work. So, little orphan Annie eyes, right? That means clear cytoplasm. They're not going to say in a USMLE question, Oh, there's orphan ani-Is in the cells, right? So you need to know what this means. So an orphan ani-I nuclei means that you have a ground glass appearance of nuclei with clear cytoplasm. Okay, that's what orphan ani-I means, because you and I both know they're not going to put orphan ani-Is on an exam. That's just not going to happen. So ground glass appearance of nuclei with clear cytoplasm is an orphan ani-I. And they will say Somoma bodies, so that's helpful. And then they're going to ask you what kind of cancer is it, and you're going to say papillary for papa, okay? Great. And this is, again, this is our most common thyroid cancer. You may get a question asking you what's the most common thyroid cancer. You're going to say papillary carcinoma, okay? Great. So continuing on with our MFAP, we talked about a follicular adenoma. We said a follicular adenoma, it has a nice capsule around it. Here is the adenoma inside, and here's the normal tissue on the outside. Going from an adenoma to a carcinoma means you're going from benign to malignant. Now we're talking cancer. So the big difference here is you see a capsular invasion. And so instead of seeing this nice border around it, you're going to see cells that are creeping out of the border, escaping out into the normal tissue. Okay? And so that's telling you these cells are starting to forget who they are, and they're starting to invade new tissues. Okay? It spreads hematogenously. We do see some RAS, AKT mutations. I don't think that's terribly important or high yield. But it's there for your learning if you're interested to know that. So here is what I was describing for you before. Here is the border of what used to be the adenoma, and you can see the cells are just bursting through. This looks like a volcano going off, right? So they're pushing through the capsule of the follicle and invading the nearby space. This is our follicular carcinoma. Medullary carcinoma, so for our MFAP, this is going to be the M, the medullary carcinoma. This is an important one to know as well because it's associated with your MEN syndrome, right? MEN1, MEN2, MEN2B. We're going to talk about all of those together, but if it's MEN2A or MEN2B, it is associated with a medullary carcinoma of the thyroid. In fact, that's really the only way to get medullary carcinoma of the thyroid. What do I mean by that? If you ever have a patient that has medullary carcinoma of the thyroid, you need to start looking for tumors in other places. Okay? Look for your pheochromocytoma. Look for the mucosal neuromas if it's MEN2B. So if you see medullary carcinoma, you can almost guarantee that they have some kind of MEN syndrome. Okay? So great. And so we'll see some local invasion, lymphatic and hematologic spread. And here is what medullary carcinoma looks like. You can see all of this amyloid deposit here. And again, this just doesn't look like normal thyroid tissue, right? This is why I put the picture at the beginning. So as we're going through, you can really compare this and see, okay, now I know something has gone very, very wrong. Moving on to the parathyroid glands. And so parathyroidism, we have a primary parathyroidism and secondary. Pseudohypoparathyroidism is fake hypoparathyroidism, and hypothyroidism, that should say hypoparathyroidism, right? Not hypothyroidism, but you get my point there. Before we move into this, could you just remind me, what does parathyroid hormone do? What is the purpose of parathyroid hormone? Very good. Very good. Increases calcium. And what does it do to phosphate? Decrease. Very good. And what does it do to vitamin D? Increase, right? So vitamin D's job is going to be to go on and increase calcium and increase phosphate. Okay, and so by increasing vitamin D, that ensures that there's enough calcium and phosphate around for the body, because parathyroid hormone is decreasing the phosphate. And so we want to have that balance there. Another thing to keep in mind, parathyroid hormone works on the bones. It breaks down bone. And it works on the kidneys, retaining calcium and wasting phosphate. Okay, so overall, parathyroid hormone by itself in a vacuum is increasing calcium and decreasing phosphate. Vitamin D is working on the GI tract. Okay, so anything that we're eating, it's absorbing more calcium and absorbing more phosphate. Okay, and the reason I just quickly review this is because we're going to be seeing arrows, right, as we did in the last lecture, and so I want to make sure that that stuff is still fresh in your mind, which apparently it is. I'm very happy. So normal hormonal functions: hypocalcemia triggers release of parathyroid hormone. Parathyroid hormone activates the osteoclasts, which are going to break down bone and increase levels of calcium. Increased calcium resorption in the distal tubules as well. So we said parathyroid hormone works at the bone and at the kidney. Vitamin D works at the GI tract. Overall, it's going to cause a decrease in the serum phosphate, and it decreases bicarb reabsorption in the distal tubules, which you very accurately told me that when we did a practice question last time, that elevated parathyroid hormone is going to cause a drop in the amount of bicarb that's around. Okay, so very good. It's going to help convert vitamin D to the active form, and vitamin D increases GI calcium reabsorption. Okay, and so parathyroid hormone does not work on the GI tract. Only vitamin D does. That's the other thing to keep in mind. Primary hyperparathyroidism. This is the most common cause of asymptomatic hypercalcemia, and typically, so here's our thyroid gland. Here is our 4 parathyroid glands. Most cases of primary hyperparathyroidism is due to an adenoma in one of these glands. So just one of the glands starts to grow out of control and starts secreting tons and tons of parathyroid hormone. We do see overexpression of cyclin D1. It's also associated with MEN1. Okay, so going again, when we talk about our MEN1, MEN2A, MEN2B, this is going with our MEN1 syndrome, our primary hyperparathyroidism. So we're already kind of making those connections there. Renal stones are what you will see when you have elevated calcium. Fractures due to breaking down of bone. And hypertension, calcium causes constriction of vessels, and so we see an elevated blood pressure as well. The glands that have the adenoma will be large, and then the normal ones will be atrophied, of course, because we have that negative feedback from calcium. And so we're going to have one big gland on the thyroid, one big gland, and then 3 tiny little specks representing what the other glands used to be, because we're having all of that negative feedback from the elevated calcium. Our elevated calcium is causing a negative feedback to all of these 3 glands. Okay. However, this gland is just not listening. Okay, great. So our secondary hyperparathyroidism, this is a compensatory mechanism due to hypocalcemia. So in secondary hyperparathyroidism, this is the body's doing what it's supposed to be doing. You have low blood calcium, and so parathyroid hormone is high. Okay, and so typically this is going to be due to chronic renal failure. In chronic renal failure, you have decreased levels of vitamin D. Okay. The kidneys are important for conversion of vitamin D to its active form, right? It has that 1-alpha hydroxylase enzyme that converts vitamin D to the active form. If you have a chronic renal failure for whatever reason, that's going to cause a decrease in vitamin D, or anything that causes you to not absorb vitamin D appropriately. Okay, so you have this patient with chronic renal failure. They have lower levels of vitamin D. The body is starting to have hypocalcemia. If you can't get calcium from your GI tract, you have to get it from the bone. And so this patient is going to have fractures, is going to have all those symptoms that we see with hyperparathyroidism. However, their calcium will just still be low. Okay? All glands will look hyperplastic here, and PTH will be elevated. Okay? So what questions do you have about primary versus secondary hyperparathyroidism? None? Okay. Does this make sense why you have high parathyroid hormone in this condition? Yeah? Okay. So other causes of high calcium levels: malignancy, any kinds of cancer. Sarcoidosis, we said this involves non-caseating granulomas. Non-caseating granulomas have macrophages. Macrophages have 1-alpha hydroxylase. 1-alpha hydroxylase activates vitamin D. Increased vitamin D increases your calcium. And so in sarcoidosis, we see the same thing. Multiple myeloma is a B-cell tumor. So you have essentially a tumor filled with B cells. Where is that B-cell tumor? It's in the bone. And so if you have a tumor in the bone, it's going to be breaking down that bone and releasing that bone as calcium. Okay. Great. Now, hypoparathyroidism. This is a problem in the production of parathyroid hormone or the response of the target tissue to parathyroid hormone. So it can be a problem with creating parathyroid hormone, say a problem in the gland, or a problem with the parathyroid hormone receptor. If the receptor is not working because of some genetic mutation, the body's not going to respond to parathyroid hormone, and it's going to look like hypoparathyroidism. Okay, so this can be surgically induced. Say you have a patient with that papillary carcinoma. Papillary carcinoma, say here's our cancer, right? And so we go in there, we want to be good surgeons, and so we take out half of the thyroid. So all of this is gone. That means we took out the parathyroids as well. Now your patient's not going to have enough parathyroid hormone and is going to start having low calcium. You can have some autoimmune destruction of the parathyroid glands. That's super rare. You're not going to get a question on that. DeGeorge syndrome is a 22q11 mutation that results in a defect in the generation of some of the pharyngeal pouches for the embryonic development. And so when you lose the certain pharyngeal pouches, that's where the parathyroid glands come from. In the 22q11 deficiency, you have an absence of your no parathyroid glands. Okay, no parathyroid glands, and that equals no parathyroid hormone, no PTH. And so those patients are going to present with low calcium. Okay, great. Low calcium presents with perioral numbness and tingling. These patients can get cataracts, mental status changes, and tetany with the Show-stick sign and the Trousseau sign. Show-stick sign is where you tap on the face and then your face twitches, right? So you tap and twitch, tap and twitch. And the way that you remember this is that Show-stick starts with CH, it's kind of like cheek, right? So you tap your cheek and you get a twitch. Trousseau sign is where you put a blood pressure cuff on your patient's arm, you inflate it, and then you tap on the hand or tap on the upper arm and you see the hand twitch. Okay, so Show-stick sign, tap on the face, you have the cheek twitch. Trousseau sign, tap on the arm and you see the hand twitch. Okay, and so those are both signs of low calcium levels. Okay, and definitely something you can be asked about on your exam. In hypoparathyroidism, what lab findings will you see? Well, if you don't have parathyroid hormone, that means you can't retain calcium. So hypocalcemia, that makes sense. Parathyroid hormone's job is to decrease phosphate. So having high phosphate makes sense too. Low PTH, duh. And a normal alk-phos. So alk-phos is a protein that's released whenever you break down bone. If you're not breaking down bone from parathyroid hormone, then you're not going to have any alk-phos in your blood. Okay? Last category we have to talk about is a pseudo-hypoparathyroidism. And so, in pseudo-hypoparathyroidism, I know it's a big, long word, very, very complicated. What I'd like you to keep in mind here is that there's a problem with the PTH receptor. There's a problem with the PTH receptor. And so, let's think through the normal physiology. Normally, we have low calcium. That's sensed by the parathyroid glands, and then we have an elevation of parathyroid hormone. That parathyroid hormone binds to parathyroid receptors, and that causes increased calcium and decreased phosphate through breakdown of bone, as well as retaining calcium at the kidneys. Now, if the parathyroid hormone receptor has a problem, then this part of the process is going to be gone. So you're going to have a low calcium and a high phosphate. Okay? However, what will happen to our parathyroid hormone levels? Are they going to be high or low? So, parathyroid hormone is not able to bind to its receptor. We have low calcium and high phosphate. In that case, what would happen to our parathyroid hormone levels? Yes, exactly. They're going to increase. But because we have some sort of mutation in the receptor, no matter how high the parathyroid hormone goes, it's not going to be able to elevate that calcium to the normal level. Okay. Other things that you see with this, wherever this mutation is, it happens to also be associated with stature. And so these patients tend to have a short stature. You're also going to see a short fourth and fifth metacarpal bones. And so the fingers, the fourth and fifth fingers are going to be shorter than normal. Okay. Just sort of some random things that you also see with this condition, but may help you get the diagnosis if you get this in a question. Okay, great. So moving right along to our adrenal glands, talking about our Cushing's syndrome, Conn syndrome, our hyperaldosteronism, congenital adrenal hyperplasias, our Addison disease, pheochromocytoma, and then our MEN1, MEN2A, and MEN2B. So again, I feel like I've kind of been beating you over the head with this today, but glomerulosa is for aldosterone, fasciculata, cortisol, reticularis, and androgens. Great. Cushing's syndrome, we said, is when we have a prolonged administration of corticosteroids. That's the most common cause of Cushing's syndrome. However, there are other causes. A tumor on the adrenal gland can also lead to Cushing's syndrome. A decrease in ACTH is to be expected here because we have negative feedback. When we're giving corticosteroids to our patients in pill form, that is going to cause a negative feedback at the level of the pituitary. And so we see a decrease in our ACTH level. Cushing's syndrome due to an adrenal tumor. Here we are going to have a decreased ACTH again because we have too much cortisol. And we're going to have an atrophy of the non-tumor tissue on the same side as well as the contralateral adrenal gland. And so here is our left adrenal gland, here's the right adrenal gland, and here is the tumor that's making cortisol. Okay, so this tumor is just pumping out cortisol all day and all night. And so because this is pumping out cortisol, that cortisol is going to have a negative feedback at the level of the pituitary. Okay, so here's our pituitary hanging out, and this negative feedback is going to cause a decrease in ACTH. So now we've decreased our ACTH. That means that all of the layers of this other adrenal gland are going to become atrophied. They don't have that ACTH stimulation anymore. It's gone. And so this adrenal gland is going to start to shrink in size. And then for the same side as wherever we have our tumor, all of the other layers that are not tumor layers are going to shrink in size as well. Okay, and so those are the two places we're going to see atrophy when you have a tumor in the adrenal gland. Okay, does that make sense? Any questions? No? Okay, great. So, Cushing's syndrome, increased gluconeogenesis, decreased tissue utilization of glucose leads to hyperglycemia and diabetes. We have increased breakdown of protein, thinning of skin, delayed wound healing, striae formation we talked about, the collagen enzymes being hyperactivated, breakdown of bone leading to osteoporosis. And then we also have some hypertension, sodium retention, hypokalemia, and metabolic alkalosis that takes place as well. And so, excuse me. Sorry about that. So looking at sort of all of our symptoms. Sorry, what? Yes, it's getting high now. It's getting very high. So our emotional disturbances of Cushing's syndrome, again, our moon phases, our buffalo hump we talk about, in this chronic stress state is what we get, as well as all these other things. We kind of went through these already together. So that's when we have too much cortisol, we call it Cushing's syndrome. When we have too much aldosterone, we call it Con syndrome, okay? This is just too much aldosterone, nothing fancy here. It's just a tumor that only secretes aldosterone, okay? And so when you have too much aldosterone, that's gonna lead to increase of your salt retention. Increased salt retention increases your blood pressure, okay? So we're gonna look for hypertension, hypernatremia or elevated sodium, hypokalemia or decreased potassium, a metabolic alkalosis, increased bicarbonate, HCO3, and low renin. Because we have a high blood pressure and we have all this extra salt, renin secretion should be quite low. And so the way that I always remembered Con syndrome, so Dr. Kahn was one of my professors in medical school, and he loved playing basketball. He was just this biggest fan of basketball. He would play basketball against the students all the time and usually beat us as well. And so there was one time that we did beat him and he got really angry. He got really salty. He was always making comments about it for the next couple weeks. And so the way that I always remember Kahn syndrome is that Dr. Kahn's team lost, so he felt salty. Okay, and that salt is referring to this aldosterone increasing the salt retention. Okay, so Kahn's syndrome leads to increased salt retention. Secondary hyperaldosteronism, and so what happens when it's not a tumor of the adrenal gland that's secreting aldosterone? Instead, we have the normal physiology that's causing aldosterone levels to get high. So what would cause aldosterone to get high? Well, if we have a decrease in the blood flow to the renal artery, typically due to stenosis of the renal artery, that's going to lead to less blood flow to the JG cells. If you have decreased blood flow, that's going to lead to renin. That's going to lead to increased angiotensin II. Angiotensin II is one of the triggers for aldosterone, and that leads to your hyperaldosteronism. So this is why it's called secondary. We have some other problem that's leading to hyperaldosteronism. Okay? And so this is, again, getting into our RAS system, which, again, I just tell you, Natalia, I'm so excited for Monday when you explain to me the RAS system. I'm just like, I'm giddy. I can't wait. Great. So next is our congenital adrenal hyperplasias. And this is going to be the last thing we discuss today because, actually maybe not, but typically this takes some time to go through. And I want to make sure you have a really firm understanding of these because you're going to have maybe about 5 to 6 questions about congenital adrenal hyperplasia on your step 1. Okay, that's a lot. That's a lot for a single disorder. And so I'm going to explain it in the complex way. I'm going to go into detail, and then I'm going to show you a mnemonic that's going to make it super easy to remember. Okay, so we're going to do the hard thing first, and then I'm going to give you the easy thing. That's the way life goes. So congenital adrenal hyperplasia, this is a disease that you're born with. Babies are born with the lack of an enzyme needed for cortisol synthesis, right? Autosomal recessive disease, the baby is born with it. If you lack the enzyme you need to make cortisol, your body's not going to be making cortisol. And so the pituitary is going to respond to this by increasing secretion of ACTH. Increasing secretion of the hormone that increases cortisol secretion, right? That will stimulate the adrenal cortex. And then what's going to happen is all of the other layers of the adrenal cortex, even though we can't make cortisol, all of the other layers are going to start to get bigger. They're going to become hyperplastic, right? And so if we were to look at here's our adrenal gland. Here's the first layer of our adrenal gland. Here is the second layer of our adrenal gland. Here's the third layer of our adrenal gland. And here is the medulla, where we make all of our epinephrine or norepinephrine. Okay, so here are our 3 layers. And so what are the names of the 3 layers going from top to bottom here? Yes. Wonderful. Beautiful. Good, excellent. So glomeruloso-fasciculata reticularis, and then which layer is responsible for making cortisol? Excellent, yes. So this part of the adrenal gland is missing enzymes that it needs to make cortisol. ACTH is coming to the adrenal gland and saying, hey, make cortisol, make cortisol, make cortisol, make cortisol. However, the adrenal gland cannot. And so it's going to respond by increasing the size of the layer of the glomerulosa layer and increasing the size of the reticularis layer. Okay, so those layers are going to get bigger, and the adrenal gland itself is going to be physically bigger. However, it's going to be made up of just the glomerulosa layer and the reticularis layer, and then you have the adrenal medulla inside. And you notice we've lost our fasciculata altogether because it can't make the hormone it's supposed to make, so it's completely gone. Okay, so that's our congenital adrenal hyperplasia. Babies are born with it. What does it look like? There's three main types that you need to know. The first type is our 21 hydroxylase deficiency. This is our most common deficiency. And so just to kind of quickly, this is what I asked you to be able to do for your exam. So if we look at cholesterol, here's our cholesterol. We're going to draw some arrows going down, and that ultimately makes aldosterone. I'm writing aldo. We have an arrows going across this way and arrows going down to make cortisol. Okay, and then we have arrows going across this way, and that's going to ultimately make our androgens. Okay. All right, great. And so we need to fill this in with our enzymes. So 17 is going to go here, 21 is going to go here, and 11 is going to go here. Okay, and because 21 and 11 are present in both layers, we're going to put a 21 here and an 11 here. Okay, great. And so if you can draw this, just what I've just drawn for you, on your step 1 exam, that is going to help you quite a bit in deciphering what will happen. Because if the question stem tells you that there's a 21 hydroxylase deficiency, and then you draw what I just drew, it took me about 30 seconds to draw this. If you draw this out and then you just go like this and then cross this out, right? You just draw a line through this, you have your answer. If you have a 21 hydroxylase deficiency, you have increased androgens. That's it. That's it. There's nothing really fancy or really crazy or complicated about this. If you're missing this enzyme you need to go down, you cannot go down. You must go across. If you go across, that means you're going to increase levels of androgens. Okay? Great. And so let's go back to the slide and see what it looks like. So this is going to be our most common. It results in virilization, meaning you're going to have, because of these increased sex steroids, you're going to have increased sexual characteristics presenting. That's what virilization means. I'm sure you know what it means, but I just sort of explain it for the fun of it. And so virilization is something that you see when you have high levels of testosterone and sex steroids. So for boys, that means you're going to have early secondary sex characteristics. And so body hair, changing of the size of the penis, things like this are what you would see in boys. For girls, you're going to see ambiguous genitalia. And so the genitalia, it will be difficult to differentiate between a boy genitalia and a girl genitalia for baby girls born with this deficiency. Okay? Great. Hyponatremia, because we lose our aldosterone. That makes sense, right? If we don't have aldosterone, if we have a block here because of this 21 alpha hydroxylase, we're not going to have aldosterone. And that's going to decrease the amount of salt. And this is going to present in the first 2 weeks of life. One mnemonic, this is not my mnemonic, I'm not crazy about it, but one way you can remember is that if you're 21, you can have sex. I mean, that's not really true, but maybe that will help you remember that 21 is associated with only androgens. Okay? I don't know, I didn't make that one up. Okay, that's someone else's. That definitely would not help me remember it. Next is our 17 alpha hydroxylase deficiency. And so do I still have that whiteboard? It disappeared. Oh man. Okay. So I'm just going to draw that again, right? We have to be able to draw this stuff. And so here's our cholesterol. I'm just writing CH for cholesterol. We're going to have an arrow that goes all the way down and to aldosterone. We're going to have arrows that go across and another arrow that goes down to cortisol. and then an arrow that goes across and an arrow that goes down. Actually, there's two here, right? And then this becomes our androgens or testosterone. Okay, I'm doing this very fast. That's why it looks so crappy. But then we fill in our enzymes. Here's our 17. Here's our 17. Here's our 21. Here's our 21. And here's our 11. And here's our 11. Okay, and so if I cut out this 17, deleted, boom, you cannot cross. What hormone are we going to see higher levels of for our patient? If we lose our 17 alpha hydroxylase, our baby is born without this 17 alpha hydroxylase, they're going to have elevated levels of what enzyme? I'm sorry, of what hormone? Well, if we wanted to make an androgen, we would need to first enter from cholesterol and then cross. However, now we cannot cross. We don't have the enzyme to make it across here to get to androgens. Okay? And so because we're missing this enzyme, everything is just going to go downwards. We can't cross here. So we're stuck with aldosterone only. Okay? And so if you had a patient with only aldosterone, what you would end up seeing is ambiguous genitalia in males. For men to develop, or for male babies to develop, I should say, you need to have some testosterone. And so if you don't have it, then the male genitalia will look ambiguous. And then because you have way too much aldosterone, you're going to end up with hypertension, high blood pressure due to too much aldosterone. I'm going to cross this out and write aldosterone because it's easier to remember that way. Okay. And then again, not my mnemonic, but if you're 17, you can't have sex and you are salty about it. So you have a lack of those sex hormones and you're salty about it, meaning you have this high aldosterone leading to elevated salt retention. Okay, great. And so again, not my mnemonic. The mnemonic that I was going to share with you that really makes these things easier is what you do is you first, right, so the different enzyme deficiencies you can have. You can have a 21, you can have a 17, and you can have an 11. Those are all the enzyme deficiencies that you will ever be asked about. 21, hydroxylase deficiency, 17, hydroxylase deficiency, and an 11, hydroxylase deficiency. And these all correspond to the things that we've been drawing throughout this session, okay? And so on your step 1 exam, what you're going to do is you're going to write them vertically like this, okay? I don't care about you writing this stuff. I don't really care about that. What I want you to do is to have on your scratch sheet essentially what I have written right here. 17, 11, and 21 written on top of each other, okay? And then the next thing that you're going to do is that you are going to write S right here, and you are going to write A right here, okay? And so what does this mean? So what you're going to do is after you write A and S, you're going to put an arrow above all the ones, okay? And now it's like, whoa, what the heck are you talking about? So this A is going to stand for aldosterone, and this S is going to stand for sex hormones. Okay? You now have the key to every single answer. So, in a 21 hydroxylase deficiency, you have an increase in your sex hormones, right? The arrow goes up, that means an increase in sex hormones. In your 17 hydroxylase deficiency, you have an elevation in your aldosterone. Right? Elevation there means increased aldosterone, and you're going to have the increased blood pressure and everything else. In your 11 hydroxy deficiency, you're going to have an elevation in your aldosterone and an elevation in your sex hormones. Okay, and so that's why you have 2 arrows there. This is probably the most helpful sort of key to answering these congenital adrenal hyperplasia questions, I think. All you need to be able to do is to write out that 21, 17, and 11, write A and S above it, and know that the A is for aldosterone and the S is for sex hormones, and then know what your patient's going to look like if either of those things are messed with. Okay? Okay. Natalia, what questions do you have? Okay, no problem. So we're going to meet on Monday. When we meet on Monday, we're going to start off with a couple of these questions about congenital adrenal hyperplasia, and then I'm going to review with you these congenital adrenal plasias one more time, just because it's late and you've been traveling, and this is just such an important topic for step one. Okay. After we do that, we have a few more things to cover. Pheochromocytoma. We're going to talk about our men's syndrome. We're going to talk a little bit about diabetes. And then after that, some of our other tumors of the pancreas. We have some questions.